So thank you for inviting me. It's lovely to see so many people. I was saying to someone over lunch, I think if I could summarise PoTS in pregnancy in one sentence, I think in my experience what women want is just simply to meet doctors, healthcare professionals who have heard of it and understand it. And I think my experience is the relief on their face when I understand the words that they're talking about is having booked with a midwife and who has to sort of Google it or Wikipedia it or something. So I think we have a knowledge gap in other healthcare professions, particularly midwives and obstetricians, and we need to somehow address that. I am no expert on PoTS and I'm no expert on pregnancy in general. I'm not an obstetrician, I'm a general physician. And for those of you who want to have a little post-lunch snooze, the main messages I'm going to make is you can just read this and then go to sleep for the next 15 minutes. So as has already been said, because PoTS affects mainly women of childbearing age, it is inevitable that a lot of patients with PoTS are going to get pregnant. And PoTS is unfamiliar to many clinicians, particularly obstetricians who won't encounter it in day-to-day practice, and midwives. It's very, very important to stress that for most women with PoTS, they will have normal, full-term, healthy pregnancies and a normal delivery. And if you start with that premise, and if I say that early on in most consultations, that is a huge relief to most women. There's a huge amount of misinformation out there, and word travels, and then the misinformation gets expanded upon. So it's important to stress that at the beginning. However, I feel that women need pre-pregnancy counselling because they will be frightened about what pregnancy could potentially do to their symptoms and what their condition could do to the baby. And most of my talk is going to be focused on the medications because that is what worries most doctors and that is what worries most women. I'm going to talk a little bit about the course of the symptoms and any effect on the baby. So if I start with the medicines, these need to be ideally discussed before the woman becomes pregnant. If you just assume that every woman will stop every drug when she becomes pregnant, then that is a very good baseline assumption. If you don't counsel women, reassure women, or they can't find the information on the internet, then the natural thing is for women to stop even maintenance thyroxine in pregnancy. So what I'm saying is that unless you counsel your patients that this particular drug or this particular therapy can safely be continued in pregnancy, she will stop it. Because she doesn't know and she's frightened, and our natural reaction is to try and protect our babies. But actually that can be a very bad idea to suddenly stop medication at any time, but particularly in pregnancy. All women planning a pregnancy, not just women with PoTS, need to take preconceptual folic acid for 3 months prior to conception and for the first 3 months of pregnancy. That is a national recommendation. It is only done by about 30 to 40% of women. 50% of pregnancies are unplanned, and even those that are planned, going through IVF units, women, those of you that have been pregnant in the audience, did you really take your folic acid for 3 months before you conceived? I didn't. But that's the advice, and women need to have that advice. And as repeatedly, the main intervention, the main thing that I do with my patients with PoTS is to reassure them about the adequate fluid and salt intake. And all pregnant women are advised to drink 3 litres of water a day. That's a lot of water. And that's if you haven't got PoTS. So when we say adequate fluid intake, it's a lot of fluid. And those glasses we had at lunch, that's part of the problem. You have like 2 sips and they're gone. That's not adequate fluid intake, given that many of you maybe didn't drink coffee and then you had something this morning. We're all probably mildly dehydrated in the room right now, and pregnant women need to drink at least half a litre with a meal. So beta blockers, first of all. I'm actually going to move away from this because I can't read my slides up there. So labetalol we know a lot about because that's the first line drug that's used to treat hypertension in pregnancy. Labetalol is actually an alpha and a beta blocker, and there's lots of data. In fact, it's one of the only drugs that is licensed for use in pregnancy. So it's not a drug that you would pick particularly to treat PoTS, but the fact that there's so much data about it allows us to be reassuring about other beta blockers. Propranolol has been around for years. We use it to treat migraine in pregnancy. We use it to treat thyrotoxicosis in pregnancy. We use it to treat and prevent arrhythmias in pregnancy. And it's a very, very safe, old, tried and trusted drug. So women on beta blockers can be reassured that they can continue that in pregnancy. Bisoprolol is an interesting one. Leslie and I have recently tried to find some data about bisoprolol safety in pregnancy, and there really isn't much. But I have to say I use it in a lot of my cardiac patients. It's a cardioselective beta blocker, and it is used in some PoTS patients, and I tend to continue it in pregnancy because there's no theoretical reason why it would be dangerous if other beta blockers aren't. I've gone the wrong way. Fludrocortisone, we know that's safe because we use it for patients with Addison's disease. It's a mineralocorticoid steroid, and it's you just got to be a bit careful. Women will sometimes play around with their own dose of fludrocortisone, so take a little bit more. You've got to be careful in pregnancy because the natural physiology in pregnancy is to hold on to salt and water. That's why pregnant women become edematous. So if you overdo the fludrocortisone, that can cause problems. So it's important to monitor the blood pressure, monitor the sodium levels. Midodrin. This is a tricky one, but it's the one that I find hardest to counsel women about. A lot of patients with PoTS are on Midodrin, and we don't have very much data about its safety. So my default position with Midodrin is to advise women to stop it. And that can cause some women problems if they found it very helpful and they don't particularly like coming off it. Most women will if you explain that there's lack of data. But it is a vasoconstrictor, which is of course how it works symptomatically in PoTS. And there is a more theoretical than actual risk that constricting blood vessels while the baby's developing can cause problems. And there has been an association with this condition called gastroschisis, which is interestingly much more common in young women than older women. So I try and avoid Midodrin. I have taken a few patients through pregnancy on Midodrin simply because nothing else will work for them and their life is intolerable without it. But if I do that, I still try and stop it in the first trimester. Remember, the first trimester up to 12 weeks is when the fetus is developing. Ivabradine, that is another new drug for which we have very little information in pregnancy. So again, I try and steer away from Ivabradine in pregnancy. It hasn't been shown to be harmful in human pregnancy, but it has been shown to be harmful in animal studies. But you can't always extrapolate animals to humans. Remember, thalidomide was safe in animals when it was tested. Octreotide I used to be an endocrine registrar, and we used to call this endocrine cyanide. It basically blocks all hormones, so it's not a good idea to give it in pregnancy, which is a very hormone-dependent state. That said, I've looked after 2 women, not with PoTS, but with neuroendocrine tumours, who needed to have octreotide, and they were fine in the pregnancy, and so were their babies, interestingly. But again, it's a drug to avoid. Pyridostigmine, I've never seen a PoTS patient on pyridostigmine. I don't know which patients you would use it for, but it's in the literature. We use it for myasthenia gravis, and it's safe. You need to give it more often in pregnancy because the natural reaction in pregnancy is to give less of a drug. And actually, what you need is usually more of a drug because the kidneys and the liver work better in pregnancy, so the drug is excreted more quickly. And pyridostigmine is a very good example. So, in fact, I've just seen a patient this morning with myasthenia gravis on pyridostigmine, and she's gone from 3 times a day dosing to 5 times a day dosing in pregnancy because her kidneys are eliminating the drug quicker. Clonidine is what the Australians used to use to treat hypertension in pregnancy. It's like a drug that we use in this country called alpha-methyl-dopa. It's a very old-fashioned drug. It has lots of side effects, but it is safe in pregnancy. And you might come across some patients who are on clonidine. So what women want to know is my PoTS going to get worse in pregnancy? And the data, by the way, all of what I'm saying is in a review that myself and Leslie and an obstetrician wrote together that's soon to be published in the Obstetrician and Gynecologist. So all the references for what I say are all in that document, which will soon be uploaded on the website. So most women actually say that they get better in pregnancy, and I didn't believe this when I first started looking after PoTS patients. I thought, surely they're going to get pregnant, their blood pressure's going to drop, they're going to feel very faint, but they don't. They actually mostly get better. And there are various theories, but the theory that makes most sense to me is that what I was saying before about pregnancy being a state of fluid retention. That fluid retention will actually help many women with PoTS. So not everyone gets better, but I would say the majority of the patients that I look after in pregnancy actually find that their symptoms improve. Like all these things in medicine, it's the women with more severe PoTS and more debilitating PoTS who tend not to get better. But if there is such a thing as an average patient with PoTS, then they mostly do get better. 15% stay the same, and about a quarter will get worse. If they get worse, a third will get worse in the first trimester, a third in the second half of pregnancy, and a third just feel terrible throughout the whole pregnancy. And it depends what sort of subtype of PoTS you've got. If your PoTS is very sort of tachycardia dominant, I don't know what the proper PoTS term for that is, but those women won't tolerate the physiological tachycardia. They just sit there and their heart rate will be 15, 20 beats more per minute than when they're not pregnant. And women who get a lot of tachycardia will experience that physiological tachycardia as a symptom. That said, normal pregnant women without PoTS will get symptomatic tachycardia in pregnancy. In fact, a large part of what we do in pregnancy is reassure women who have a normal tachycardia that it's normal. So that can be a problem, and the physiological hypotension can be a problem. So I've looked after 3 or 4 patients now who only get PoTS when they're pregnant. And I don't know if that's a thing, but in my experience, it is a thing. They're absolutely fine when they're not pregnant, but they present for the first time in pregnancy, and when they've had their baby, they're absolutely fine. And they have debilitating fainting, such that they can't leave the house, they can't get to work. I remember one patient vividly just couldn't, she was all right when she got to work, she just couldn't get there because she couldn't stay upright long enough to travel. And she was absolutely fine outside pregnancy. And again, if it's a problem early in pregnancy, as you become more pregnant, you retain more fluid, and therefore you will often improve later on in the pregnancy. So my tips for those of you that look after pregnant women with PoTS is that don't try and lump them all together. One size doesn't fit all, and what works for one patient will not necessarily work for all of your patients. I spend quite a lot of time speaking to women about avoid deconditioning, because the natural reaction, if you get symptomatic when you stand up, is not to stand up and not to do anything. And that is actually very bad and makes things worse, and they then become very unfit and deconditioned, and then find the end of pregnancy and delivery very, very difficult. I stress the fluids a lot and the salt. I prescribe routinely packets of crisps and Marmite on toast for breakfast. And women look at me like I've gone bonkers, but it does really work, especially the Marmite, because it makes you so thirsty, it makes you drink a lot. But, not everyone likes Marmite. So we also advise, listen to your body, rest when you feel you need to. And this doesn't work in summer because it's too unbearably awful. But if you're pregnant during the winter months, wearing compression hosiery, as it's politely called, can really help a lot of women. I've had several patients who say, yes, I was drinking a lot, yes, I was increasing my salt intake, but I put those stockings on and my life was revolutionized. And then they will wear them if they make them feel better. What affect women worry? They don't worry about themselves, they worry about their baby. And so it's very reassuring to be able to tell women that there's no association between adverse maternal outcomes. It doesn't increase the risk of miscarriage, preterm delivery, perinatal mortality, or stillbirth. And that's really important. There's some data in the literature that suggests they get more symptoms of nausea, vomiting. I'm not sure that that isn't just a response to the hypotension. I don't know. I haven't noticed that my PoTS patients get more vomiting than any other patients personally. There will be discussions about giving birth. And here is where you have to disabuse women of some of the misinformation and disabuse some of their doctors. There's nothing that annoys an obstetrician more than a non-obstetrician recommending a caesarean section. It makes them steam come out of their ears. You wouldn't recommend to a neurosurgeon that somebody needs brain surgery. And so you shouldn't really recommend to obstetricians that someone needs a caesarean section. You may well be right, and there may well be concerns, and a few women with very, very severe PoTS simply just cannot go through normal delivery, but it is an exception. I can only think of one patient that I've looked after where we all agreed that she should have a caesarean section, but she was bedbound for most of the pregnancy. When you look at the literature, the rate of vaginal delivery in women with PoTS is exactly the same, which is about 75%. And we stress to these patients, like we do with all patients, that vaginal delivery is safer for the mother and safer for the baby. And once you explain that, it's normally self-evident. The issue with planning delivery in these women is the anaesthetist. The point here is, again, women want reassurance that whoever is putting a needle in their back has heard of PoTS, knows the likely reaction to anesthetics and opioids, knows about the need for fluid. In fact, on the train on the way here, I was reading an email from one of my obstetric anaesthetist colleagues who's seen a very, I don't want to call her tricky because it's the disease that's tricky, not the patient, but she's got very difficult to control PoTS symptoms. And she's had a very early referral with the obstetric anaesthetist because she's so frightened that the people that she meets when she delivers aren't going to understand her condition and the effect that playing... What anaesthetists do, basically, is play with your vasoconstriction and vasodilation with their drugs. So they give you an epidural, which vasodilates you. Then they very quickly give you another drug, which vasoconstricts you. And if you've got PoTS, you don't take kindly to being vasodilated and then vasoconstricted in rapid succession, and it can make you feel very, very ill. So it's all about knowledge, and provided the anaesthetist knows, and the woman sees the anaesthetist before she meets him or her in labour, all is well. These women can have epidurals, they're given slowly and carefully, there's obsessional control of fluid balance, and don't forget that when women are in labour, they often don't drink very much, and they're often dehydrated. And so all some women want is just reassurance that they're going to be attached to an IV infusion, and then that's all they need. Interestingly, very, very, I find this fascinating. I used to worry a huge amount about the association between joint hypermobility syndrome and resistance to local anaesthetics, and I've met many patients for whom this is a real problem when they go to the dentist. Don't ask me why, but when you put the local anaesthetic in the epidural space, it's not a problem. It's a problem when the local anaesthetic is infiltrating locally, so it's a problem when she needs her episiotomy stitched up, but it isn't a problem with epidurals. I don't know what the physiology of that is. It might be to do with how the drug is not deployed, but how it gets around the CSF or the epidural space. But it's not the case that women with EDS or joint hypermobility need lots and lots of anaesthetic, or that their epidurals don't work. They do work. So the only issue here really is giving them enough support of their circulation so that because it's invariably will get vasodilation when you give an epidural, even if you give it slowly, and that's even more marked with a spinal for a caesarean section. So it's forward planning. That's all that we need here, really. After delivery, we encourage early mobilization. Again, stockings. When you're breastfeeding, you need to drink more anyway. So again, stress the importance of fluids and pacing yourself. And this is what I say to patients with multiple sclerosis as well, that when families offer to help, you just have to give them jobs to do. Having mothers-in-law hanging around expecting to have a cup of tea and a cake is hopeless. What you need is the mother-in-law to actually go make your dinner and put it on the table and clear up after her. Women are, there's lots of cultural issues here, but I say to my patients, when people offer to help, say yes, but give them constructive things to do. People hanging around when a new baby's born to coo and, hold the baby is just people in the way. They need to be more constructively helpful. And people love a list of things to do, that will occupy the mother-in-law. So here's the shopping list, off you go. We were discussing over lunch why it is that women get better after pregnancy. And I find this also fascinating. I think it's multifactorial. I think pregnancy is a massive distraction. That's not to say that their symptoms aren't real, but it's certainly... I have now met 2 women who were in a wheelchair throughout their pregnancy and walked in to see me a year later to show me the baby. And I said, oh, you look great. What are you? They're off all their treatment. There is something real and physiological about pregnancy improving PoTS, and I don't know what that is. It's not just me nagging them to not let themselves decondition. There's something real about it. So I'll stop there just to say in summary, women with mild or moderate PoTS have similar pregnancy outcomes to the general healthy population, but they need to be reassured of that fact. There's no risk to the baby that we know of, and many of the drugs, but not all of them, can be safely used in pregnancy and breastfeeding, and therefore there's no reason not to encourage women with PoTS to go ahead with pregnancy, provided they plan it and speak to their doctors and carers about particularly some of the drugs. Thanks very much. I'm happy to take any questions.